All right, everybody. We're going to go ahead and get started so you can be cognizant of your time. Again, my name is Chad Dixon. I'm the Director of Marketing here at myMatrixx. And we're going to go through a few housekeeping items before we begin the presentation. Today's webinar will last approximately 1 hour with questions at the end. In order to receive your CEU, in order to receive your CEU credits, you must be active and attentive throughout the entire webinar for 50 minutes minimum. We will be handling questions at the end of the presentation portion. So through the first 50 minutes, you can type your questions into the chat box, and we will be noting them, and then we'll answer them at the very end. Next, I'm going to go ahead and introduce the speakers. Phil Walls is the Chief Clinical Officer here at myMatrixx, a leading workers' compensation pharmacy benefit management firm. Phil Walls oversees its clinical program, including drug regimen reviews, formulary management, and clinical educational programs. As a clinical pharmacist with over 35 years of experience in pharmacy, healthcare, informatics, and workers' compensation, Phil has particular expertise in pain management, side effects of medications, and managing overutilizations. Our next speaker, Dr. Stephen Stanos, is currently the medical director at myMatrixx and an attending physician in the pain and headache clinic at the Swedish Medical Center in Seattle, Washington. At Swedish, in addition to overseeing occupational medicine services, he is working to develop a pain rehabilitation continuum of care for the Swedish medicine and Providence healthcare system. First up will be Phil Walls.
Great, Chad, thank you very much. Thank you all for joining in today, and I'm just going to let you take a second to look at the objectives, and while you're doing that, let me describe today's program. We're basically going to have two sections. The first is going to cover urine drug testing. I'm going to present basically some facts known about both drug abuse and urine drug testing, what the guidelines say. And then we're going to take a few minutes where I'm going to ask Dr. Stanos some real-world questions, many of which actually have come from clients that have talked to me over the years about this subject, because we just feel it would be very important for our clients and prospects to get an understanding for what Dr. Stanos and other physicians actually face out in what we'll call the real world. Then the second half, we're going to look at the evolving field of genetic testing. I'm getting a lot of questions about this, and so Dr. Stanos and I just felt like this would be equally as important as the urine drug testing, and we're going to do the same type format. I'll describe what is known about genetic screening today, and then ask Dr. Stanos a series of questions. Now, when I was doing my research, and I think many of you that know me know the Wall Street Journal is always a source of amazing material. I came across this quote from last November from a Dr. Robert Wadley in Raleigh, North Carolina, who stated, "Urine drug testing is how I pay the bills." Now, for the record, Dr. Wadley, I don't think does a lot of work in workers' compensation. I think most of his billing is to CMS. But I think that's important today. I think we need to recognize this is not just a workers' compensation concern. The other interesting thing I found was he's in North Carolina, not California, because most of what I hear when it comes to outrageous fees is coming from California. So this just sort of sets the stage. Urine drug testing, physicians are doing a lot of it, and they're charging a lot. And for the record, neither Dr. Stanos nor myself are opposed to urine drug testing. In fact, just the opposite. We encourage its appropriate use. What concerns us is when we see our clients being overcharged for necessary services, and equally as bad, overutilization of necessary services. Now, how do you protect yourself against this? Let's just sort of get the financials out of the way up front. I've been in front of audiences on numerous times now where I am hearing complaints about the urine drug testing industry in terms of fees that range $2,000, $3,000 for a patient screening, and quite frankly, that is outrageous. I've also for years been hearing concerns about what appears to be double charges, when in actuality the charges aren't duplicative, but they're being charged for a screen and then a confirmation test. As I've talked to different urine drug testing companies, basically what I've found is that if our clients will enter into contracts with these companies, and four of the ones that come to mind in alphabetical order are Aegis, that's AEGIS, Ameritox, Dominion, Millennium, and all of these I would encourage you to Google them to find out more about them. But they're all willing to enter into contracts, and the going rate seems to be about $300 to $400 for a workers' compensation panel. Now, at that point is where you'd really want to start getting into the details of what the contract specifies. But I would recommend that you have a workers' compensation panel, meaning when a doctor orders the test, all the drugs on that panel will be tested. Now, there is then the likelihood, though, that there might be a drug that wasn't on the panel, that for whatever reason in a particular patient, you need that drug added. I know a lot of these companies will include in the contract that add-ons to the panel will be at no charge. And then lastly, so that you don't see those duplicate tests I was talking about, both screening and confirmation tests should be included at one charge. And then also, you definitely want to make sure that the service is going to include interpretation of results. And then lastly, I just want to make sure that everyone realizes that the PBM you're working with should not be receiving financial incentives for recommending a patient. I want to make a real quick check here on my screen. Okay. Now, some background on why urine drug testing is important. Opioid use for the management of chronic pain has been increasing dramatically over the past 20 years. Opioids are the primary option for severe pain, but as we all know, they produce euphoria, which can lead to dependence and in many cases addiction. Predicting who's going to become addicted is very difficult to do, and it's not necessarily easily diagnosed. And as we're going to see, the home medicine cabinet is actually a primary source of drug diversion. Now, some of the sources of where pain relievers are obtained, and this was rather surprising to me. We all think of all the different things that go online, especially the internet, and how easy it is to obtain drugs. Well, as it turns out, what has been found is that the vast majority of drugs that are being used inappropriately are coming from a combination of receiving from a friend or relative or from just visiting one doctor. And for those individuals who are receiving drugs that they shouldn't from a friend or a relative, the person that originally got those were getting them from one doctor. So this sort of goes against all of those preconceived notions we have about doctor shopping, pharmacy shopping, illegal internet sites. It's largely the treating physicians who are prescribing the drug, and then it's ending up being diverted into street use. Now, another important thing to remember about the urine drug testing is this is only one part of an overall risk reduction strategy. Overall, what we're looking at is to make sure that legitimate patients, or patients truly in pain, will have access to opioids. But individuals that are just trying to obtain these drugs illegally off the street or otherwise, we want to keep it away from those. And then when someone does become addicted, they need to be identified and provided the appropriate medical care. Now, the things that should make up an overall strategy, one is baseline risk screening, opioid risk tools, things of this nature. Prescription drug monitoring programs, or otherwise known as PDMPs. 49 states now have this very valuable tool, and unfortunately it is still underutilized. Number three, something as basic as pill counts. This is where the patient is required to bring the prescription vial in to make sure they still have the correct number of pills remaining at that point in time. Very simple test to do. Psychiatric assessments. Identify those patients that have a higher risk of abuse. Objectively monitoring the therapeutic benefit. Many of you have heard me say before, when it comes to opioids, if they're not working, they should be discontinued. And then lastly, urine drug testing. So urine drug testing is important, but it's not the only tool that we have available. Now, why is it necessary? Well, as we all know, prescription drug abuse is on the rise. We have a national epidemic. As we saw just a moment ago, the major source of these abused opioids is coming from prescribers. And then it's long been known that patients that are on chronic opioid therapy are a lot more likely to end up abusing opioids. Not a surprise there. So who should be tested? Well, we could say only those at high risk of abuse, or maybe everyone regardless of the risk level. Everyone, but maybe do the high-risk patients more often than low risk, or only those that exhibit some type of aberrant behavior. Well, there's really no evidence to support any one of these approaches as the best practice. So let's look at what some of the guidelines say. The American Pain Society, American Academy of Pain Medicine looks at those high-risk patients should periodically obtain urine drug screens. Those that are not at high risk should consider periodic drug screens as well. It's a very physician-friendly type approach to what should be done. The American Society of Interventional Pain Physicians say that it should be implemented from initiation of opioid therapy along with subsequent adherence monitoring. And then they also say that a physician should create a urine drug testing policy that is applicable universally and consistently so as to destigmatize urine drug testing. This is very important. The patient has to understand that a physician testing them does not necessarily mean he or she doesn't trust them, and this can go a long ways in accomplishing that. ODG said it should be done at the onset of treatment. If patients ask for a specific drug, indicating possible diversion, if the patient has a positive addiction screen, if they have already exhibited any aberrant behavior, if dose increases are not decreasing pain and increasing function, and then of course follow any state guidelines in addition to that. But I think ODG does a very good job of spelling out when this should be done. And then the ACOM guidelines. All patients on chronic opioids for chronic pain, they should be tested at baseline and then randomly at least twice and up to 4 times a year. And then in addition, for cause. So if there's any sign or suspicion of aberrant behavior, go ahead and test at that time. So let's look at 2 different types of prescribers, Prescriber A and Prescriber B. Prescriber A has a gut instinct for when he or she believes someone should be tested. They consider it random for everyone, but it's based on assumed risk factors. Prescriber B has a strict policy, and everyone gets treated the same. So let's talk about the gut instinct approach. Well, what we have found in a study by Cornell University is that doctors identify a lying patient only 10% of the time. And sometimes people who are telling the truth are erroneously identified as actors. So not a very reliable approach. Another study in 2011 looked at 549 patients, and doctors missed 60% of the patients who went on to have abnormal urine drug tests. So basically, this approach that a physician can necessarily tell who should be tested is not very reliable. In this particular study, 470 patients were examined. 45% had abnormal urine drug tests. 20% had the presence of illicit drugs. 14% had the presence of non-prescribed prescription drugs. And then 10% had the absence of prescribed drugs. So there's definitely a need to do urine drug testing in patients, without a doubt. In this audit that was performed back in 2007, basically what they found that the urine drug tests were instrumental in referring 40% of patients for treatment for addiction. In addition, they discovered signs of abuse in over 19% of patients. So again, there are plenty of studies pointing out the usefulness of these tests. Now, another question that comes up a lot is, why are there different types of tests? Well, there's basically two different ones, immunoassay and chromatography. Chromatography is also referred to as gas chromatography, mass spectrometry. Basically, the immunoassay is a lot less expensive, or should be a lot less expensive, and it's relatively quick. It can be a useful screen, but it has limitations that we're going to talk about. Chromatography, on the other hand, is considered the gold standard. It is more expensive, but it's the only reliable confirmation test, and it does take longer. So it has to be sent off, and then you have to wait for the results. Now, what can be determined when we test? Well, we can determine the presence of illicit drugs, the presence of non-prescribed prescription drugs, and the absence of prescription drugs. What we cannot determine is the amount or time when a drug was taken, whether or not a concentration was toxic, and whether or not the concentration actually correlate with what the doctor prescribed. So there's limitations to all of these tests. Interpreting the results are also very, very important, because misinterpretation of the results can have serious repercussions. Both false positives and false negatives can be a problem in the clinical setting, and false positives can have very dire consequences for a workplace screen. Now, in terms of interpreting it, the physician may not be the best individual to do that. Back in 2007, again, a 7-question test was given to 114 physicians. Of those that employed urine drug testing, none of them answered all 7 questions correctly, and only 30% answered more than half correctly. And then when compared those to physicians that don't use urine drug testing, the ones that do were no more knowledgeable than the ones who don't. So there's limited knowledge of how to interpret these results. That's why part of the service has to be correct interpretation. Now, looking at immunoassays, if you Google this, also refer to it as point-of-care testing, you'll find numerous companies that provide this service to physicians. As you can see, it's a relatively inexpensive proposition for the physician, $13 per test, and of course if he or she buys in quantity, the price goes down. So not a very expensive test. Now, these are some of the drugs that can be screened, and highlighted in blue. These are some of the ones that cannot. You cannot use the immunoassay or the in-office testing for oxymorphone, fentanyl, meperidine, or levorphanol. Now, another problem with the immunoassays is a high number of false positives. We're not going to go through all of these, but I think it's important that you realize that some of these drugs can appear to test positive, when in actuality the patient could be telling the truth that they were never taking that drug, that they were taking something else. For example, with amphetamine, some of the OTC allergy medications that contain antihistamines or decongestants can cause a positive test. Phencyclidine, or PCP, something as common as dextromethorphan, or the DM component of cough syrups, can cause a positive test. Now, I know we're going through these slides rather quickly, but these will be available on our website if you want to go back to take a look at these. Marijuana, certain NSAIDs can cause positive tests, and on down the list. Now, if you're going to be involved with physicians that are doing urine drug tests, it's very important that you sort of determine what the prescriber's perspective is. So we have here a series of suggested questions that you might want to ask the doctor, just to reinforce this. So number one is, has that doctor designated him or herself as the only prescriber of controlled substances? In other words, if they entered into a patient-provider agreement. Ask if they're going to be performing UDT to monitor compliance and aberrant behavior. Ask in advance how often the patient will be tested, whether or not the test will be random. Ask if they give allowance for the first infraction. That could be important to note. Also ask about what's the policy regarding second infractions, and then give them the suggestions. Are they going to discharge the patient, refer the patients to substance treatment, or wean the patient? Ask them if they consider cannabis to be an illicit drug, a very controversial subject right now. Then ask also if they will agree to discuss the results with a toxicologist, an expert in the field of these studies. And then ask what their policy is regarding patients that refuse testing or who refuse to produce a sample. Now, next, you also may want to consider coordinating with your pharmacy benefits manager. If nothing else, make sure the patient has quantities on hand at the time of the test. Otherwise, there's going to be some misinterpretation. This example here, very simple. Patient A and patient B both prescribed the same drug on the same day in the same quantity, and yet because of differences in prescribing, one patient is going to be technically out of medication in 10 days, whereas the other patient, it should last 30 days. So these are the type of things that should be considered the day of the test. And then, in the absence of a prescribed drug, solicit or demand a response from the physician. An example of how to go about doing that is presented here in this slide, just a very simple letter to the doctor. And then when it comes to the physician's response, again, ask him to indicate if he or she is going to discharge the patient, refer to substance treatment, or wean the patient, and if not, why do they feel that the results were not inconsistent? It's putting them on the spot, but sometimes that has to be done. Now, at this point, I want to ask Dr. Stanos a series of questions about some of the things that we've just gone through. Dr. Stanos, how are you today?
I'm good. Thanks, Phil, for having me.
Certainly. Thank you for joining us. Now, recently I was talking to a client, and a member of the audience asked me how often a physician should perform urine drug testing on a patient. And, of course, my response was to go through, just like we have in these slides, what some of the guidelines say. At the conclusion of that answer, she then informed me that the physician is located in California and that he performs urine drug tests on all of his patients on a monthly basis. Is there any justification at all to testing like that?
Well, I would just first comment that, and I think you alluded to this earlier, that urine drug testing is helpful. It's not perfect, but it's many times one of the few tools that we have to really uncover aberrant behavior, addiction, and many times diversion. So I think it's been helpful for many practices. And unfortunately, though, maybe over time this has been, I think the case you present with the physician doing this with every patient, all patients every month, is obviously excessive. You had mentioned the ACOM guidelines and some of the other guidelines around the country. They do give a lot of leeway to physicians on when they should do this because this is such a tough science and kind of an evolving area with regards to forensics and medical legal issues. But I don't think it's appropriate with every patient that you're seeing. I don't know more about this physician's practice, but I think the ACOM guidelines and some of the other guidelines stating that you should do this at the initiation and the evaluation of the patient, whether it's at the time of initiating therapy or if you're referred a patient that you're going to be taking over their medications and they've been prescribed by somebody else. And I think most importantly, too, that it's tied into what you mentioned, looking at the prescription monitoring program. That many times can help answer a lot of the questions and actually collaborate that with the urine testing as well.
Okay, thank you. Now, along a similar line, that is the appropriateness of testing or not. Another client asked me about the appropriateness of testing for patients that aren't prescribed controlled substances.
You know, I think that, again, not knowing more details beyond that, I think on the surface, I really couldn't see that that would be within a standard practice or standard of care. I've seen that in some cases that I've reviewed that physicians were doing that. There'd have to be some justification of what they were thinking, but on just kind of peripherally looking from afar, that to me would not be appropriate. Again, you always want to look to see what are they justifying within their note. I'd imagine in this case they're probably not justifying anything, but obviously you want to get take a deeper dive from the physician, from the notes on what they're thinking. But I think on the surface that's not appropriate.
Okay, good. I completely agree with that. Now, another thing that I encounter quite often, both from clients that get results or when I were clinical pharmacist or talking with treating physicians, there seems to be a population of physicians that will order the test, receive results, but they seem to ignore those results. What I'm referring here especially is the presence of illicit drugs. The illicit drugs, street drugs, will show up, and yet the physician continues to prescribe opioids and other controlled substances. How does the physician community feel about those bad actors?
Well, I think it's been pretty clear that if you're going to use any type of test, whether it's an MRI, an EMG, in this case, urine testing, if you don't follow up on the results, I think from a medical legal standpoint and from a patient safety standpoint, the physician is putting themselves at huge risk. Many times, I think, in the kind of busy nature of practice, sometimes results may fall through the cracks, and like any type of test, I think most clinics try to have safeguards and how effectively and efficiently they follow up on tests. But reviewing a chart and seeing that a person is positive for heroin and the physician continues to prescribe, I think that physician medical legally is really putting himself at risk, and obviously the patient or the person that's on heroin. So yeah, I think that's just a lapse in medical care, and would be considered practicing outside of the standard.
Bring up a very good point, and I know the audience is frustrated because sometimes it doesn't seem like the DEA acts fast enough. I would encourage folks to actually go to the DEA's website and look at a section they have called Cases Against Doctors, and you will realize just how active they are at tracking down these bad actors and actually shutting down these practices. So very good point.
Yeah, and I would comment, Phil, I think too, and unfortunately the pain community, and especially the workers' comp industry, was probably too close to what happened with pill mills, because a lot of those patients may have been within the comp system and would own a pill mills. Hopefully the pill mill reaction from the DEA and trying to shut these down, whether it be in Florida or in other parts of the country, have been hopefully effective at really stemming some of the issues that happened 4 or 5 years ago. But it's a tough job for the DEA. It's hard to many times from a state-to-state standpoint intervene with physician practices, but a lot of this is just really egregious practice patterns by a small number, and unfortunately they're causing a lot of the problems.
Yes, definitely. Now here's the really tough question. What do you do about the presence of marijuana, especially in states that have said that it's so-called a legal drug?
Well, I'll tell you, I'll give you 2 different points. I have been practicing in the state of Illinois. Now I'm in the state of Washington, where there's a legalized marijuana. I have a DA license like all physicians that are prescribing medicines. Marijuana THC is still Scheduled 1. That means it's research. It has, according to the DA, no clinical value. And so in our clinic, and what we've been kind of wrestling with is if you're going to prescribe opioids or controlled substances, that really, at least in our clinic, that patients can't be actively using THC. So really it mixes a state law versus federal. Again, physicians, our DA license is a federal license, and so if you look at it from a technical standpoint, it's still considered illegal. That being said, I've had patients that I've evaluated just in the months that I've been here in Seattle, and I've had 3 patients that are using medical marijuana, and again, this is just my own observation. Most of those, I don't think they overtly were impaired, but I don't think it was helping their pain significantly. There may be an indication for some patients with regards to medical marijuana for appetite and for anxiety, but I just think from a pain management standpoint, the evidence is less, and I haven't really seen a great response. The cannabinoids, CB1, those different analogs have been in development for a number of years, even before the state initiatives for medical marijuana. And unfortunately, those products are available, a very kind of clean version of a compound of marijuana that's used for pain, and the results are still inconsistent. So I just think, going back to your original question, I have a DEA license. It's still Scheduled 1, so I don't think it's appropriate. But I think every physician needs to weigh that with what their hospital policy is and be consistent, and that could vary. And I know there's probably some physicians that may think differently, but I still think you need to look at what the DEA and what the federal government is saying.
Okay. So just to sort of recap for the audience, for you personally, when you see the presence of marijuana, you consider that still to be an illicit drug, and therefore we treat it like any other illegal drug.
Right, and I give the patient the option, and if I'm going to continue to prescribe for them, they're going to need to stop, and I offer them treatment if they think they need treatment. It's like anything, you need to have just an open and direct conversation with the patient, and then if you explain your reasoning, I think they can understand that. And I've had some patients that decided they wanted to continue to use marijuana, and I explained that I would treat their pain, I just wouldn't use controlled substances, and I documented that, and I continue to treat the patient. So you don't want to abandon the patient. You want to be honest with them, and again, the dialogue is the most important part.
Okay, very good. Now, New York has proposed legislation that would have made the use of urine drug testing mandatory for patients receiving these drugs. myMatrixx was actually very much opposed to that legislation, not because we're against urine drug testing, but because the way the legislation was written, there was no corresponding burden on the physician to do anything with the test results. In other words, if he or she ordered the test, and yet even if the patient was positive for heroin and they continued prescribing opioids, they had met the letter of the law. And we just felt like that was going to drive up cost without any return to our clients. But aside from the way the law was written, these type laws to me always sort of come across as mandating the practice of medicine. And again, for our audience, I'm just curious, how do you feel when states try to pass laws forcing physicians to do the right thing?
Well, I think it's always been a question, and again, there's this, different states have more aggressive or less aggressive state medical boards. I think a lot of times physicians, especially the pain physicians, don't feel that the state medical boards understand some of the complexities with treating chronic pain patients. I think that's the reason why guidelines are out there. Guidelines are not mandated, but I think they give kind of evidence-based recommendations, and then again at the next level the physician uses, or clinician uses, their professional judgment to make the right call. So I think most physicians and most healthcare providers don't want to be mandated to do anything. Again, I think more importantly, especially with urine tox screens, it's more how you use the test versus just mandating that it be done. And if you misuse it and not follow up on it, it's really worthless.
Yeah, I completely agree with that. My last question on this section, we talked about earlier, there's multiple tools available to assess risk. We have the state guidelines, we have ACOM, ODT, prescription drug monitoring programs, along with urine drug testing. Where do you feel like the urine drug testing fits into this overall spectrum in terms of importance?
Well, I think it's part of what's been described in the past as universal precautions, and I think you alluded to it earlier that it's hard to look at a patient and say, oh, and I think you showed in some of the number of the studies, it's difficult for physicians to make the proper call by just talking to the patient, even if we know some of their risk factors for misuse. So I think the universal precautions is the kind of lowest level of risk management you can apply to every patient that you encounter to hopefully minimize risk. And so doing a patient agreement, but understanding what's in the patient-physician agreement, checking the nutrition monitoring program, and also understanding some of the issues with those, but having it as part of your practice. So I think urine toxicology screening is just an integral part and may be more important for some patients versus the other. But really going back to doing the questionnaires, doing a good history from the patient, taking a good history from the patient, using tools. There's different questionnaires that patients can fill out in the waiting room that takes them 2 or 3 minutes. Even those are based on subjective reports, what they're telling you, that also can be helpful. So going back to your question, I think the urine screens are part of the tool. If physicians are just doing urine screens and not these other things, I think they're going to be fooled and they're going to have problems with the results and interpreting them. So really it's just part of the big picture for risk management.
Okay, excellent. Thank you, Dr. Stanos. We're going to move on now to the second half of the presentation. We're going to be talking, of course, about genetic screening. And to sort of put this in perspective, let's take a look real quick at adverse drug reactions. There are 2.2 million severe adverse drug reactions each year. It's the 4th leading cause of death in the United States, 100,000 deaths per year caused by properly prescribed drugs and another 80,000 caused by improperly prescribed drugs. It is the cost leader for insurance malpractice payouts. So what does this have to do with genetic screening? Well, the idea is that a lot of these could be avoided if we knew in advance how a patient is going to react to a particular drug. 75% of the population has genetic variations affecting something known as CYP450, which is basically the gene that's going to control how a drug is metabolized. So as we look at this little chart showing patients taking a particular pill, there's a portion of the population that's going to respond appropriately to a normal dose. And there's a subset of the population that's going to respond to a much lower dose, and then another subset that's going to require a higher dose. And then there's going to be those patients that aren't going to respond to that drug at all, and instead are going to need an alternative. In order to do that without some type of genetic screening, it really requires a lot of trial and error. So this whole concept of personalized medicine is very, very attractive. However, it can also be very, very expensive. If we were to do a full panel of all genes for a patient today, you can expect to pay between $3,800 and $4,000. Now, the companies involved in this, again, just to name a few, there's Iverson Genetics, Genelex, Pathway Genomics, and again, Millennium Labs are all involved in doing this, and I believe they will negotiate on these prices, but I don't think it's nearly to the extent that I described for the urine drug testing. Another alternative to doing a full panel screen is to only screen for those genes involved in pain. That can get the price down to $1,000, $1,500. But the concern there is the drugs being used for pain aren't the only ones that are of concern. So it could be worthwhile in the long run to go ahead and do the full panel, keeping in mind that group health care considers this to be a once-in-a-lifetime test. And they're only going to pay for it once, and that means they're going to be paying for a full panel. Now, this brings up something interesting, and I don't think we have time to get into it today, but if group health care has already done a full panel on a patient, that would be very valuable information to workers' compensation. I don't know how accessible that would be, but if a patient would allow it, that could certainly have some value on the workers' comp side. Now, pharmacogenomics, what is that? Well, this is looking at the variations in genes that dictate how a patient is going to respond to particular drugs. And basically, we're going to be able to predict if the patient is going to have a good response, a bad response, or no response at all in some situations. Now, we think that about $300 billion a year is wasted by prescribing drugs to patients where the drug is completely ineffective because that patient doesn't carry certain genes, including pain medications. We know that patients can either metabolize drugs slowly or very, very quickly, so that you can actually go from a patient being underdosed because the drug is metabolized so fast and cleared that it really didn't do anything, to other patients where what would be considered an average dose can actually be an overdose because it's going to remain in their system for so long. So without this, physicians are really put at a state of having to sort of go with a trial and error approach. So there's a huge attraction to this, this silver bullet called pharmacogenomics or personalized medicine that's going to make all that go away, but at a cost. Now, the genes listed here are the different panels that are going to be looked at, and below are some of the drugs that are going to be affected. Now, the vast majority of these are not going to be significant in workers' compensation. So that's why payers will have to be making decisions on whether or not they want to do a full panel or just look at certain subsets of these. Now, with opioids, which is, I think, in workers' compensation where I've seen most of the marketing for genetic testing go, keep in mind that we already know patients have significant variability between how they're going to react to these drugs, by as much as a 40-fold difference between patients. And that is huge. That's a very big number. As I said earlier, it can go from a drug being completely non-effective to being an overdose for certain patients. Now, the CYP2D6 is an enzyme in the liver that metabolizes codeine, which codeine in itself is inactive. It doesn't do anything. The body has to convert it into morphine before it can actually have an effect. So codeine is converted by this enzyme into morphine. Now, variations in how that occurs is either going to mean that codeine is not going to be metabolized, therefore not converted into morphine, and basically completely ineffective in a patient, or in another patient, it's going to be converted very, very quickly, leading to very high levels of morphine, which could lead to an overdose situation. Another commonly used drug in comp, hydrocodone. Again, same enzyme, CYP2D6, is responsible for 95% of its conversion to hydromorphone. And then once it's converted to hydromorphone, that drug has a much greater affinity for pain receptors. So anything that inhibits hydrocodone from being converted is going to lead to a much lesser effect in those particular patients. So this is why, as we've looked at how our knowledge has evolved, we sort of have to go from a point of what was, I think, oversimplification, where it was long believed that if a patient doesn't respond, they're tolerant, therefore we have to increase the dose. I think today we have to look at it more from a standpoint of patient doesn't respond. There's very good likelihood that they have some type of a genetic variation that's causing that. Now, other drugs that are affected by this same gene include tramadol, hydromorphone, oxycodone, and oxymorphone. So it has a wide-reaching effect on all the opioids. Now, when it comes to how patients respond to pain, outside of the genetic variation, we've always thought, well, patients have different variation in response to pain sensitivity. There's differences in patients based on weight and age. There's differences based on prior opioid use and development of tolerance. And then there's just differences in the bioavailability of various opioid formulations. All of those are still true statements. We're just adding one more element to that, which is, of course, the genetic testing. So if we were able to do the genetic testing on all the patients, one, if a patient was deficient in the CYP2D6, then they would have very poor relief from drugs like tramadol, codeine, hydrocodone, and oxycodone. In addition, we could use the genetic testing to predict the response that patients are going to have. And then in addition, the physician could maximize the efficiency of the pain medication and decrease the risk for overdose. So the ideals from this new science are quite compelling. Finding the correct drug at the correct dose would be made much, much easier. We would basically be hoping to eliminate that trial and error approach to prescribing and dosing drugs the way we do today. Now, who needs pharmacogenomics testing? I know there's marketing suggesting that all patients be placed on or have these tests before they're placed on an opioid, and in an ideal situation, that could be worthwhile. However, we all have limitations on resources, especially financial resources. So let's break it down a little bit. So first of all, let's look at a patient that has no pain relief and no side effects. Well, they could be an ultra-rapid metabolizer. In other words, they're clearing that drug out of their system so fast that it basically has no effect at all. On the other hand, a poor metabolizer is going to have severe side effects even at low doses. So that patient needs lower doses, but again, sometimes that can be too late because the initial dose could have been too much. So genetic testing can be a once-in-a-lifetime approach to evaluate the patient. It's a very simple, relatively simple test, which simply requires either a saliva or a buccal swab. And then if we're only going to look at pain medications, then we only need to do the CYP 2D6 rather than the full panel. But in the long run, for the patient's care, full panel could be more appropriate. So with this, Dr. Stanos, I'm going to come back to you and ask another series of questions. Now, the things that I was describing regarding slow metabolizers and ultra-fast metabolizers, physicians have been aware of this far longer than genetic science has been able to test for it. I think the question is, have physicians traditionally used this knowledge to adjust doses appropriately in these patients? If they are, that's great. But if they're not, should our audience expect the genetic test to produce any different results than what the trial and error approach was doing previously?
Well, I think I would first comment, and I'm glad you're covering this because, again, it's probably one of those new areas in pain, and I think only time will tell in the next 1 or 2 years how this pans out. I think it's first very important, and you mentioned this, that most of the genetic testing before has been done in the psychiatric field where they're writing a number of different antipsychotics, different medications with significant toxicities and interactions with different enzyme systems. So that's probably where most of the work had been done before. I have to disclose I don't do this type of testing in my clinic, and I know there are some physicians that I've talked to that have started to do some of it. But I think originally it was done in the psychiatric field. And even with that, it was dependent on certain physicians. If you think about metabolism, though, of meds, the P450 2D6 system, yes, it's involved in, I think, 50 to 80% of medication breakdown. You know, the body wants to break down the medicines to be less toxic forms so they can excrete the medicine. But P450 is just through the liver. That's phase 1. Mechanisms, but there's also a number of drugs that are glucuronidated, or what's called phase 2 metabolism, that don't affect the P450 2D6 system. So this doesn't impact every medicine we prescribe. It is important, though, that some of these are opioids, but also a lot of the medications, especially the HIV medications, fluconazole, some of the antibiotics, they also can have an effect on this enzyme system, which could affect toxicity or efficacy. When you had mentioned the genomics, and I'll try to keep this brief, it's interesting, and we're talking just about medication metabolism. There's genetic variability with receptors, our mu receptors, our opioid receptors. So this is just one small piece of a very complex body and neurologic system. So it's not some black and white, oh, you're a high metabolizer or low, so I'll do this. And I think what we've done clinically is physicians are dosing by titration and response, clinical response. So yeah, I think this could be a potential tool, but this is just a really small part of a very complex nervous system, and that's why it's challenging for us to, decide who's getting an effective response to any medicine we use, whether it's an opioid, an anticonvulsant, or an antidepressant.
Okay, very good. You and I have had a chance to talk about some of the information that we've seen out there regarding both genetic testing and urine drug testing, where some of the claims being made are presented like scientific papers, but they actually seem to be more marketing pieces, often lacking some of the significant information, even like just the total number of patients that might have been examined in a study. Are you aware of any peer-reviewed articles that have looked at the results of urine drug testing or genetic screening on patient outcomes?
I think there's a lot more literature in the urine drug testing literature, mostly looking at databases, and unfortunately, and even if you go to DEA meetings or FDA meetings, and they're trying to look at this with regards to opioid overdose and death epidemic with opioids, there's large databases that are looked at, but the data sometimes is hard to interpret, and there's a lot of different surveillance programs that look at that. And so most of that work has been done on the urine toxicology screen side. They're mostly from individual state databases, and they may be able to show, kind of from a large epidemiologic standpoint. So you have to be cautious how you look at those, because those are very difficult to to interpret. So on the other side with the genomics, I'm not aware of specific recommendations from any pain communities or pain societies or position papers related to that. That may be something that happens slowly over time.
Okay, all right. Well, knowing that, and I think you hit it spot on that it is difficult to interpret. For our audience, if a physician is already following guidelines as they should be doing, what additional benefit can our clients obtain by paying for genetic tests?
Well, I would say if this was done for the right intention from a clinical standpoint, where I see it as potentially helpful would be the very recalcitrant patient that's been on a number of different medications. They've had trouble dosing medicines. They've needed high doses. That may be something to really justify it. Methadone, buprenorphine, those two medications, and especially methadone, significant number of deaths per year in patients, not just patients, but substance abusers that are dying related to toxicities. A lot of that in kind of the uncertainties of why some of these patients are dying, and many of these people we thought were on stable doses, may be related to drug-drug interactions. So I think in that population it may be helpful. If you look at, unfortunately, methadone, it goes through a number of different systems, CY3A4, there's 4 or 5 different enzyme systems. So it may be effective because there is such a greater risk for death with methadone. So I hope that kind of gives you a little better picture. But I think the physician really needs to justify and in the note explain why they're doing this test, what are the real reasons, versus some kind of tool that they're doing in all their patients without really any clinical goal.
That is helpful. Would it be fair to say that we are not at a point where it would be appropriate to do genetic testing on all patients prior to starting opioid therapy?
Again, I would say that with my disclosure that I don't do this type of testing yet, but I think that would be something, since it's so new and an evolving area, that this would have to be really at a utilization level reviewed by another physician, again, in those special circumstances. Now, that may change in 2 or 3 years as this evolves, or maybe even an easier answer to say no to at that time.
Okay, all right. My last question for you on this subject. We all know that there is a percentage of bad actors in the physician community that drive up cost by overusing tests like these. Can you give our clients any advice on how to identify those bad actors and mitigate those costs so that they can actually benefit when a physician is doing it the right way?
Yes, I think it's a good point to make. I think as a physician, and a lot of us are frustrated because you want to use certain tools in your practice, and then kind of a more egregious use of that tool has started to be used primarily for financial reasons, and then it's hard to get that approved for a legitimate patient. Whether you look at the overuse of MRIs, the overuse of urine toxicology screens, I think an individual case-by-case basis, many of these tests can be helpful, but then when they get misused and then insurance companies tighten the reins, and then it's hard to actually get things approved for the patients that need it. So I think physicians in general are frustrated with that. Yes, there's bad apples, and I think they are low-hanging fruit. That the interaction, I think some of the letters and that myMatrixx uses to reach out to these physicians to get them on the record to explain why they're doing certain things. And many times the physician may just be naive. Just that small interaction from the stakeholder standpoint, in that case here being the PMP, actually make change or cause some change in the physicians. But I think a lot of times there's no interaction and no questioning of what a lot of these clinicians are doing, so they can kind of get away with it. But I think if there's something in the record, they may start to behave better. But most of these patients, there's really no regulation, and I think that's why we see such excessive use. And if someone knows they can get away with it, they're really going to take advantage of it.
Okay. So sort of to summarize, because, primary question we wanted to answer today is, can these tests impact outcomes? And what I'm hearing you say is, acknowledging that there's the bad actors that are overusing and overcharging for these type services. When used judiciously, there are situations where they can improve outcomes. either by detecting illicit drugs or detecting patients that shouldn't be prescribed certain drugs like methadone. So there's a place for it in therapy, but definitely should not be used on every patient every month, things of that nature. Now, Steve, before we run out of time, I know that you spent most of last week in Washington, D.C. Do you have a moment just to share some of the things you took away from that?
Yes, and actually, thanks for letting me do this. The American Academy of Pain Medicine meeting was last week in D.C., and it covered a number of different areas. If you can go to the next slide, I think, and I just wanted to let you guys know, I think there's some exciting things going on in pain, and many times, and especially in the workers' comp, we concentrate on opioids and some of these other issues. But, you know, the federal medicine, because of the wars, unfortunately, we've been involved in, there's been a really increase in improvement in treatment of pain on the battlefield. There were some interesting presentations on auricular or ear acupuncture that they're using in the battlefield. There's also been some really interesting step care models for treating chronic pain and psychiatric conditions. Unfortunately, a lot of our wounded soldiers are coming back with PTSD and other psychiatric problems. And so there was really some great presentations on the VA and the Department of Defense really putting together a very, I think, well-managed pain management algorithms, and a lot of those are actually being picked up by the private healthcare system. The other one was that there's been mentions and there's been a development of some federal registries to actually do a better job to kind of centrally look at different data related to chronic pain and treatment of chronic pain. So those registries now are actually up and running, and that's also, I think, going to help answer a lot of the questions we have out there that have been difficult with regards to some of the impact of pain on function and addiction, abuse, all those different things. So that's very exciting. There's been talk for many years about these registries, but it was good to see that they're actually moving forward. The last thing I'll just touch upon is the National Pain Strategy, and this was the keynote at the meeting. The National Pain Strategy was related to the Institute of Medicine report in 2011 that came out saying that we, as a whole, government and all the different stakeholders have done a poor job of managing pain. The National Pain Strategy was a group that put together recommendations. We put those recommendations to the HHS on improving multidisciplinary management of pain from the primary care level all the way up through the inpatient and outpatient and tertiary care settings. That report's going to be coming out soon. It is going to give guidance on how pain should be managed first for Medicare and Medicaid, but there is the understanding that this is going to be picked up by a lot of the private players. We were hoping that the report would be released, but we're waiting for HHS. So I just wanted to let you know on the workers' comp side that this National Pain Strategy, we're hopeful is going to be good news to help change the way we care for patients with pain. And so I just wanted to make you guys aware of that it's going to be coming out any day now.
Okay. Excellent. Thank you very much for that. And yeah, I know the audience will be, as I will be, watching for that. Okay. Chad, at this time, I'm going to turn it back over to you.
All right. It's 2:02 right now. We have a few questions from the audience that we wanted to address. So I guess the first one is from Michelle Krause. And I believe we're getting high price UDS on claimants from both the physician and the lab. Is there any way to put the access? Oh, I'm sorry. We're getting high price UDS claimants from both the physician and lab, sometimes over $3,000 for both. Example, physician would bill us for $10,000 or so for 11 units. Have you heard of that? Is there any precedent set for that?
Dr. Stanos, I'll go ahead and address it first. This is the first time I've heard $10,000. I've heard some outrageous amounts, but that's a new one there. I do know, and of course this would all be contractual, but in my conversations with some of these companies, I have heard some of them say that a contracted rate can be retroactive. So if I were you, I would be on the phone to the company that did the test and just ask them to explain it, talk to them about a contracted rate, and see if something couldn't be done that way.
Yeah, this is Steve. I think that's obviously outrageous, that amount of money. We just I would disclose here. We use point of care. It's all regulated by our hospital system. We do point of care testing, and it's I think the charge is over maybe $100, and we get a small amount back. We do send for confirmation in some of those patients, but that's just I think totally over the top, $10,000. Yeah. I'm not surprised because I have heard similar numbers, and I'm just amazed, and I hope people aren't paying for that.
Yeah, it's such a necessary test, and yet those kind of charges are making it, it's putting it outside the reach of most patients that need it. Okay, Chad?
Yep. And another question from an adjuster who's having issues with getting a physician to take over care for a patient who has failed the urinary drug screen. How would you handle that situation?
Well, there's obviously probably more to the on the facts about that, but a physician needs to address the urine screen results and then give a recommendation based on those results or their other clinical judgment. So it's unfortunately, without any more information, that's difficult to answer more than that. Phil?
I would agree with you. A very difficult situation.
Yeah, I think what's important too is really documenting what the exchange is, and I think one thing that I've learned, and we try to teach physicians, is even asking for the urine screen, you have to first ask the patient, what meds are you taking? Go through all of them. Ask them specifically, do you smoke marijuana? Do you drink alcohol? When was the last time you took a benzodiazepine? So you can answer those and have that in the chart, and then you offer them and tell them that you're asking for a urine tox screen. And I'm always amazed how the answers quickly change. So just having a person and giving them a urine cup and saying, here, we need a sample, you really need to kind of go through the steps in the right way, and you want to document it the right way.
Very good.
All right, we've got time for one last question. Can you comment on the usefulness of saliva testing for drug testing, oral swab tests for usefulness and or effectiveness, and does it test for a nucensa versus urinary drug testing?
We don't use it. I know there's been some research out there looking at saliva, and I think in some of the OCMED clinics they're using it for basic screens for illicit substances. So there are some issues where it could be sensitive, but again, I think it's evolving. I don't have any other experience with it, but I do know that it is something with regards to ease of use that has been offered, and it's out there, but I don't think it's a real standard practice yet. Again, I think it's one of those niche areas that's going to continue to evolve.
Yeah, then Steve, I am aware of one company that's doing this almost exclusively, and one of the advantages is, the subject patient can never claim that they can't produce a sample, and so that is a significant advantage. And from what I know, the results are as reliable as the traditional urine testing.
Mm-hmm. All right, we've come to the end of today's webinar. I'd like to thank our many guests, panelists, and speakers. After the webinar is concluded, it'll be posted on the myMatrixx webpage where you can actually download a copy and or view it again. In addition, you will receive a link via email for all of your CEU credits. You'll have to fill out a few forms, and then the credits will be mailed to you. If you have any questions, feel free to reach out to me directly. And again, my name is Chad Dixon. Thank you.